When you first step into medical training as a learner, whether you're a brand new intern just hitting the wards, or maybe a resident trying to survive your first night on call, the sheer volume of information it feels like an actual physical weight on your
Oh,
chest.
absolutely. It's a profoundly daunting cognitive load.
Right, because you look at a standard textbook on respiratory medicine, and it is hundreds of pages thick. You're staring down thousands of symptoms, hundreds of differential diagnoses, endless radiological signs.
And obscure syndromes, yeah.
Exactly. It feels like you're expected to somehow download an entire medical encyclopedia directly into your brain before morning rounds even start.
And honestly, that's exactly where a lot of brilliant, really capable minds get completely bogged down in clinical practice. They try to memorize the forest by staring obsessively at every individual leaf,
Like trying to memorize 20 different symptoms for pneumonia.
right? And then another 20 for a pleural effusion. And they try to hold all of that in their working memory. But human memory under the stress of a crashing patient is fragile.
Which brings us to the core of what we are doing today. What if there was a structural cheat code?
I like that phrasing, a cheat code.
Yeah, but not a shortcut that lets you, skip the hard work of understanding medicine, but a framework that makes the rote memorization obsolete. Imagine taking that massive textbook of chest pathologies and replacing it with just a single elegant mental table.
10 core pathologies and 10 absolute rules of physics.
It sounds like a bold claim, if you're listening to this right now.
It does, but it is the absolute foundation of clinical mastery because clinical medicine, especially when we're talking about the respiratory system, is not about rote memorization of random symptoms. The human chest is a mechanical box.
Right, it's physics.
Exactly. It's about physics. It's about fluid mechanics, acoustics, structural engineering, and understanding exactly why a change in human tissue fundamentally alters sound, movement, and vibration.
So if you're listening to this right now, whether you are that medical resident prepping for board exams, an intern terrified of missing a diagnosis, or just someone fascinated by the sheer elegance of how the body works, consider this your comprehensive audio masterclass. We're essentially building a massive mental slide deck today.
A diagnostic framework so robust that you will be able to deduce almost any chest condition just by looking, feeling, tapping, and listening.
Because the human body is constantly broadcasting its own internal structural integrity, isn't it? It tells its own story long before a CT scan or an X-ray is ever ordered.
To read that story, though, we have to master the alphabet of this physical language. And that relies on the 4 absolute pillars of the physical exam: inspection, palpation, percussion, and auscultation.
Right, but before we start diagnosing those 10 core pathologies, we have to understand the baseline, right?
We do. We have to know what normal looks like so we can recognize when the physics actually change.
Okay, let's start with the eyes then. Inspection. Before I even lay a hand on the patient, I am standing at the foot of their bed looking at the overall shape of their chest. And if I am looking at a healthy, normal adult, I'm assuming I shouldn't be seeing a perfect cylinder.
You should not know. We are evaluating symmetry and proportion. So if you look at the patient horizontally from the foot of the bed, you are observing 2 primary dimensions.
The front to back and the side to side.
Exactly. The first is the anterior-posterior diameter, so the distance from the sternum in the front of the chest to the spine in the back. The second is the transverse diameter, which is the distance from the lateral aspect of the left rib cage across to the right rib cage.
And what's the normal baseline there?
In a healthy adult, the ratio of the anterior-posterior diameter to the transverse diameter is roughly 5 to 7.
5 to 7. Okay, so it's wider from side to side than it is from front to back. It's an oval.
An oval is a really good way to conceptualize it. The human lungs are literally designed to expand within that specific geometric space.
But I'm thinking about the mechanics of chronic lung disease. Let's say a patient has severe emphysema, someone who has smoked for decades, and their lungs have lost their elastic recoil.
Right, their lungs become chronically hyperinflated.
Yeah, they're constantly trapping air that the patient can't fully exhale. Over years and years, I imagine that constant, unrelenting outward pressure from the trapped air would have to physically change the bony architecture of the chest wall.
Your intuition on the mechanics is spot on there. In severe emphysema, which is classically seen in late-stage COPD, the lungs act like balloons that have just lost their elasticity. They inflate, but they don't deflate properly.
So they're just constantly pushing outward.
Precisely. Over time, that constant outward pneumatic pressure actually remodels the ribs. The anterior-posterior diameter extends outward until it roughly equals the transverse diameter. That normal 5:7 ratio distorts into a 1:1 ratio.
The chest literally becomes a circle, a barrel chest.
A barrel chest. The sternum pushes forward, the ribs become more horizontal rather than sloping downward, and the entire rib cage basically sits in a state of permanent inspiration.
Wow.
And this is a bilateral symmetrical abnormality because emphysema typically destroys both lungs globally.
Okay, so a symmetrical change tells me we have a global bilateral problem, like chronic air trapping. But what if I'm looking at the chest and the symmetry is broken? What if the left side looks completely different from the right side?
Asymmetry is a massive clinical red flag. It immediately tells you that a specific localized pathology is occurring.
And how does that usually look?
When you observe asymmetry, it will present in one of two distinct ways: a unilateral bulge or a unilateral retraction, meaning one side of the chest is either pushed out further than the baseline oval or it is sunken inward.
I see a potential trap here, though. Let's say I'm standing at the foot of the bed, looking at a patient whose left side is visibly higher than their right side. Just by looking at the static shape, how do I know if the left side is the diseased side bulging abnormally outward, or if the left side is actually the healthy baseline and the right side is the diseased side retracting abnormally inward?
That is a very common trap.
Right, because without knowing their baseline shape, a bulge on the left looks identical to a retraction on the right.
That is one of the classic diagnostic dilemmas. But overcoming it requires a beautiful, really simple clinical maneuver. You don't just look at the static shape, you evaluate the dynamic mechanics.
Oh, you make them breathe.
Exactly. You ask the patient to take a deep, forceful breath in. As they inspire, you watch the movement of the chest wall closely. The side of the chest that is fundamentally healthy will expand outward and upward normally.
And the sick side.
The side of the chest that is diseased will have significantly reduced or completely absent movement.
Oh, I see. The diseased tissue is structurally compromised, so it just becomes frozen. If that high left side doesn't move when they take a breath, but the low right side expands beautifully, then the left side is the problem. It's a bulge.
You've got it.
But if the high left side expands normally and the low right side just sits there frozen, then the right side is the problem. It's a retraction.
You have just deduced the cornerstone of the entire physical exam, which brings us to rule number 1 of our master matrix.
Okay, jot this down if you're building your mental slide deck.
This is a rule with virtually no exceptions, and it must be anchored in your mind. Chest movement is decreased in all chest diseases.
All of them. That feels like a very bold absolute to state in medicine. We rarely say all.
I know, but it is an absolute dictated by physiology. Think about the mechanisms that can cause disease. If a lung has a massive tumor, that solid mass cannot expand. If the alveoli are filled with inflammatory fluid from pneumonia, they cannot inflate further.
Okay, makes sense for solid stuff.
And if the lung has collapsed and deflated, it cannot pull air in. If the pleural space outside the lung is filled with a liter of fluid or pressurized air, the lung is physically compressed and restricted from moving.
What about something less structural, like just inflammation?
Even if the disease is just severe inflammation of the pleural lining pleurisy, the sheer agonizing pain of the inflamed linings rubbing together will cause the patient to subconsciously splint and freeze that side of their chest to avoid the pain.
So whether it's a mechanical blockage, an acoustic disruption, a structural collapse, or just pure pain, the physiological end result is always identical. The movement stops.
Rule 1. Movement is universally decreased on the affected side. That is an incredible anchor for the diagnostic framework.
It simplifies the cognitive load immensely because once you identify which side has decreased movement, you have isolated the pathology to that specific hemithorax.
Precisely.
So we've looked at the shape and we've evaluated the dynamic movement. We've used our eyes. Now we bring in our hands. Palpation. But when I think about palpating for lung disease, my instinct is to immediately put my hands on the rib cage.
Which is what most beginners do.
Right. Yet the classical clinical approach dictates that the very first place we go isn't the chest at all, it's the neck. We palpate the trachea. Why are we starting our physical exam of the lungs by feeling the windpipe?
Because the trachea acts as the structural needle on our internal diagnostic compass. It provides immediate, undeniable evidence of the pressure dynamics happening deep inside the thoracic cavity.
Okay, how so?
Well, normally the trachea sits perfectly central in the neck. You evaluate this by placing your finger in the suprasternal notch, that little dip at the base of the throat, and gently checking the space between the firm cartilage of the trachea and the thick sternocleidomastoid muscle on both the left and right sides.
And in a healthy patient, those spaces should be perfectly equal.
Correct. But the trachea doesn't just float freely in the neck. It plunges down into the chest and physically tethers to the lungs and the mediastinum of the central compartment, holding the heart and major vessels.
It's a continuous anatomical structure. So because it's tethered to the mediastinum, if the physical pressures or the structural integrity inside either side of the chest cavity change, the mediastinum will shift.
And it will drag the trachea right along with it.
Which introduces rule number 2, tracheal shift. If rule 1 was about movement, rule 2 is about internal pressure. How do the mechanics of this shift actually work?
It is pure Newtonian physics. Think of it strictly through the lens of pushing and pulling. Let's revisit the unilateral bulge we discussed earlier.
Okay.
If something abnormal is taking up massive amounts of extra space inside one side of the chest cavity, say a massive pocket of fluid pooling outside the lung, which is a pleural effusion.
Or a massive pocket of free air trapped in the chest cavity, a pneumothorax.
Exactly. That extra volume acts like a hydraulic or pneumatic ram.
It drastically increases the pressure on that side of the chest. And since the rib cage is rigid bone and can only expand so much, that pressure has to go somewhere, so it pushes inward against the center.
Yes. It pushes the entire mediastinum, the heart, and consequently the trachea away from the diseased side. The trachea shifts to the opposite, healthy side.
A bulge pushes away. That makes perfect mechanical sense. But what about the opposite scenario? What if we have a unilateral retraction?
If you have a retraction, it means the lung tissue has lost volume and shrunk. This happens in a massive collapse of the lung lobe, also known as atelectasis, where the air is absorbed and the tissue crumples inward.
And it also happens in severe fibrosis, right? Where heavy scar tissue forms and actively contracts as it heals.
Yes. So if the lung tissue is shrinking and contracting, it acts like a tightrope. It's anchored to the chest wall on one side and anchored to the mediastinum on the other.
So as it shrinks, it pulls the center toward it.
The negative pressure and the physical contraction pull the mediastinum and the trachea toward the diseased side. So fluid or free air will push the trachea away. Collapse or fibrosis will pull the trachea toward the lesion.
Okay, I have to ask about the barrel chest patient we discussed.
Yeah.
The emphysema patient with chronic air trapping. They have vastly increased volume in their chest, so shouldn't their trachea be pushed?
Think about the symmetry. Emphysema is a global systemic disease caused by decades of smoking or environmental exposure. It destroys the alveoli in both the left lung and the right lung simultaneously.
Oh, right, it's bilateral.
Because the disease is bilateral, the increase in volume and pressure is relatively equal on both sides. The left side pushes right, the right side pushes left. The forces basically cancel each other out. Therefore, in bilateral diseases like emphysema or bilateral asthma, the trachea remains perfectly central.
It's a tug of war where both teams are equally strong, so the rope doesn't move. The physical logic here is just so satisfying. So our eyes and our fingers have already told us about the baseline shape of the chest. We found the diseased side by watching for decreased movement, and we've determined if the disease is creating a high-pressure pushing force or a low-pressure pulling force via the trachea.
And we have done all of that without requiring the patient to do anything more than take a single breath.
Amazing. But to dive deeper into the actual composition of the diseased tissue, to figure out if that lung is filled with water, air, or solid scar, we have to evaluate how the body handles acoustic energy.
Which brings us to the physics of sound and arguably the most fascinating, mind-bending masterclass of this entire framework. Tactile vocal fremitus, or TVF.
Tactile vocal fremitus. It's an incredibly elegant clinical sign that bridges acoustics and touch.
Let's break down the terminology. Tactile means touch. Vocal means voice. Fremitus is a medical term derived from Latin, meaning a vibration or a tremor.
So we are literally feeling the vibration of the patient's voice through their chest wall. How is the technique performed?
You place the ulnar border, the pinky side edge, or the flat palms of your hands firmly on the patient's chest wall. You systematically move from the top of the lungs down to the bases, always comparing the left side to the right side at the exact same anatomical level.
And while you're holding your hands there.
As you hold your hands in place, you ask the patient to speak a deep, resonant word.
Right. I know in standard English medical training, we are taught to ask the patient to say the number 99, but the source material for this clinical framework notes that in Arabic medical training, the standard is the number 44, pronounced arbawa arbanin.
Yes, the specific word itself doesn't actually matter. The physics of the sound wave matter. The number 99, or arbal wa arba'in, are packed with low-frequency resonant vowel sounds.
So when the patient speaks, those low-frequency acoustic waves travel from the vocal cords, down the larynx, into the trachea, branching out through the bronchial tree, vibrating through the millions of tiny alveoli, and finally striking the inner boundary of the chest wall.
And when those sound waves hit the chest wall, the acoustic energy transfers into mechanical kinetic energy, and your hands feel it as a physical buzz, a vibration.
But the diagnostic power of TVF comes from understanding exactly how different states of matter conduct that acoustic energy.
Right.
Okay, let's build the physics model. I need to understand why sound travels differently through sick lungs. My initial naive assumption would be that if a lung is diseased and broken, it won't work as well, so the vibration should just always be weaker. But I know that's not true.
It is not true, and unraveling why requires us to look at the molecular density of the lung tissue. To conceptualize this, I want to use the cup analogy. Let's start with a normal, healthy lung. Think of a normal lung as an empty cup.
Well, it's not actually empty, it's filled with air.
Correct. In physics, air is a gas. And what do we know about the molecular structure of a gas? The molecules are highly energized and spaced very far apart, moving randomly.
Right, they're bouncing all over the place.
Because the molecules are so far apart, acoustic energy has a very difficult time transferring from one molecule to the next. The energy dissipates quickly. Therefore, air is actually a very poor conductor of sound.
So when a healthy person says 99, that sound wave has to fight its way through a massive volume of poorly conducting gas before it ever reaches my hand.
Exactly. The vibration you feel on the chest wall of a healthy person is the baseline normal TVF. It is relatively subtle. You only learn what normal feels like through the repetition of examining hundreds of healthy patients.
All right, normal lung equals a cup filled with air, which is a bad acoustic conductor, giving us our baseline buzz. Let's apply this to pathology. What happens in our emphysema patient, the one with the barrel chest?
In emphysema, the alveolar sacs are chronically hyperinflated and structurally degraded. The walls between the alveoli break down, creating massive, abnormal spaces filled with trapped gas. Our cup is now vastly overfilled with air.
If normal air is a poor conductor, then having twice as much air must act like heavy acoustic insulation.
It does. The excess air dampens the sound waves significantly. The acoustic energy dissipates long before it reaches the chest wall. Therefore, when you place your hands on the chest of an emphysema patient and they speak, the vibration is severely muffled or completely absent. TVF strictly decreases.
More air equals more insulation, less vibration. That tracks perfectly. But what if the lung isn't filled with extra air? What if we have a patient who comes in with a high fever, a productive cough, and a raging bacterial infection deep in their lung tissue? Severe pneumonia.
In severe pneumonia, the body mounts an immense inflammatory response. The capillaries leak and white blood cells rush into the alveoli to fight the bacteria. Those microscopic air sacs completely fill up with liquid pus, inflammatory exudate, and solid cellular debris.
So the spongy tissue solidifies.
Yes, this pathological state is clinically referred to as consolidation. The spongy, air-filled tissue literally consolidates into a dense, solid mass resembling litter tissue.
Going back to our analogy, you have taken the empty cup of air and completely filled it with water.
And how do the physical properties of a liquid or a solid compare to a gas?
The molecules are packed tightly together. They are physically touching. So if you hit one molecule with acoustic energy, it instantly transfers that energy to the next molecule.
Liquid and solid tissues are excellent conductors of sound because the fluid and solid debris inside the consolidated lung perfectly bridges the anatomical gap between the vibrating bronchi and the inner chest wall. The sound waves of the patient's voice travel incredibly fast, efficiently, and with almost zero loss of acoustic energy.
So the lung transforms from an acoustic insulator into a high-speed acoustic cable.
It does. When you place your hands over a consolidated lobe of the lung and the patient says 99, the vibration hits your hands with startling, almost aggressive intensity. The tactile buzz is vastly stronger than on the healthy side. TVF strictly increases.
That is wild. The sickest, most infected lung actually produces the strongest physical vibration.
Counterintuitive, but physically sound.
And this increased vibration would also happen if there was a cavity in the lung, right? Like a lung abscess that has a thick wall of inflammation and a pool of fluid sitting inside it.
Yes, a condition known as cavitation. The dense wall of the cavity and the fluid inside it provide an excellent medium for acoustic transmission. Consolidation and cavitation both increase TVF.
Okay, I'm tracking the physics. Fluid is a great conductor, so fluid increases the vibration. But let me throw a wrench into the matrix. Let's talk about pleural effusion. A patient has heart failure or maybe a pleural malignancy, and they weep liters of fluid into their chest cavity.
A massive buildup of liquid.
Right, so if fluid is a great conductor, a massive pleural effusion should give me the strongest TVF imaginable, right? It's like a giant acoustic waterbed.
This is the trap. This is the exact conceptual hurdle that trips up almost every junior resident on their first rotation. A massive pleural effusion strictly decreases TVF. In fact, it often abolishes the vibration completely. Your hands will feel nothing.
How is that physically possible? We just established that liquid is an excellent conductor. You can hear whales singing across oceans because water conducts sound so well. Why does the water in a pleural effusion stop the sound?
Because in acoustics, conductivity is only half the equation. The other half is impedance, and specifically, acoustic impedance mismatch at boundaries.
Okay, unpack that for me. Where are the boundaries?
Location is everything. In consolidation, the pneumonia, the fluid, is inside the microscopic alveoli. It is structurally integrated into the lung tissue itself, directly contiguous with the bronchial tree where the sound originates.
So it's a straight shot.
Exactly. The sound wave travels continuously from the air in the bronchus directly into the fluid-filled alveolus. But in a pleural effusion, the fluid is not inside the lung.
The lung tissue itself might be perfectly fine.
Right. The fluid is pooling in the pleural space, the anatomical gap between the outside of the lung and the inside of the chest wall.
Oh, I see. Let's return to the cup analogy. Imagine you take your empty cup of air representing the lung. Now place that cup inside a much larger glass bowl. Then fill the space between the cup and the bowl with water.
The water represents the pleural fluid.
Okay, the lung cup is floating inside the fluid bowl.
When the patient speaks, the sound wave travels down the airways and hits the edge of the lung. It is trying to transmit from the air-filled lung across the visceral pleura into the dense layer of water and then across the parietal pleura into the solid chest wall.
That's a lot of physical boundaries.
It is. And every time a sound wave hits a boundary between two mediums with drastically different densities like air and water, a phenomenon called acoustic impedance mismatch occurs. The vast majority of the acoustic energy does not cross the boundary. Instead, it reflects backward.
It bounces off.
Yes. The sound wave hits the wall of pleural fluid and bounces back into the lung.
Oh, the fluid isn't acting as a conductor because the sound can't even get into it. The stark transition from the airy lung to the dense fluid wall acts as a total acoustic mirror.
The pleural fluid acts as a physical and acoustic insulator, completely separating the vibrating lung from your hand resting on the chest wall. The sound wave just dies at the boundary. Therefore, over a pleural effusion, TVF decreases to 0.
That is an absolute light bulb moment. Fluid inside the lung wire in consolidation boosts the signal because it becomes part of the circuit. Fluid outside the lung pleural effusion cuts the wire because it creates an impenetrable boundary.
If you understand that single concept, you will never confuse an pneumonia and an effusion on a physical exam again.
Let's distill all of this physics down to the takeaway for our diagnostic matrix. Because of the poor conductivity of air, the insulating properties of boundaries, and the loss of structural tension, TVF is decreased in almost all chest diseases.
Let's list them.
Pleural effusion, decreased due to the fluid barrier. Pneumothorax, decreased because free air in the pleural space acts as an even worse acoustic barrier. Emphysema, decreased because of too much insulating air in the alveoli.
Keep going.
Lung collapse, decreased because the airways are often blocked so the sound can't even reach the deflated tissue. Fibrosis, decreased because the thick scar tissue restricts the necessary vibration.
You have listed them perfectly. TVF is decreased globally across the vast majority of pathology. It is decreased in all of them, except for two very specific, highly distinct conditions: consolidation and cavitation.
And in those two, and only those two, the physics align to create an unbroken, high-density conductive path and TVF increases. So if I am examining a patient in the emergency department and I feel a roaring increased vibration under my right hand, I don't need to cycle through 10 possibilities. My diagnostic matrix has instantly collapsed down to just two options. They either have a consolidated pneumonia or a cavitating abscess.
You are already miles ahead of the physician who is just trying to memorize symptom lists. You are diagnosing with physics.
We have visualized the dynamic movement of the chest. We have palpated the structural push and pull of the trachea. We have felt the acoustic vibrations of the patient's voice to determine tissue density. But up until this point, we have relied on the patient taking a breath or speaking a word.
Which isn't always possible.
Right. What if the patient is unconscious or in so much pain they can't speak? It is time for us to generate the acoustic energy ourselves. We move to Module 3. Percussion. The drummer's diagnostic.
Percussion is arguably the most recognizable and heavily practiced physical skill in the chest exam. It is fundamentally biological sonar.
Sonar. I love that.
You are physically tapping on the chest wall to send an acoustic shock wave into the tissue beneath. By listening to the pitch, the duration, and the resonance of the sound that bounces back, you can determine the precise density of the underlying organs.
It's tapping a watermelon to see if it's ripe, but with life or death consequences. Now, the sources are incredibly pedantic about the exact physical technique required here. You don't just knock on the chest like you were knocking on a door.
You definitely do not. The technique is paramount because you must generate a clean, reproducible sound wave without dampening it. You place your non-dominant middle finger firmly and flatly against the chest wall. This finger is called the pleximeter.
Pleximeter, got it.
You must ensure that only the middle phalanx of this finger is touching the skin. Lift your other fingers away so they don't absorb the vibration.
Okay, non-dominant finger pressed hard between the ribs.
Then you use the tip of your dominant middle finger, the plexor. You curl it so that you are striking with the very tip, almost with the fingernail. You strike the middle joint of your flat pleximeter finger.
And crucially, the kinetic movement must come strictly from the wrist, not from the elbow or the shoulder. It's a relaxed, sharp flicking motion, like a percussionist lightly striking a snare drum with a drumstick.
Yes. And the moment you strike, you must immediately pull the striking finger back.
Because if you leave the striking finger down, it acts like a mute on a guitar string. It kills the resonance.
Exactly. You dampen the recoil. Another vital rule of technique that many overlook. Your flat pleximeter finger must always be aligned parallel to the expected anatomical border of whatever underlying structure you are trying to map out.
Wait, why does the angle of my finger matter?
Because you are trying to find the precise line where the tissue density changes. For example, if you were percussing down the right side of the chest to find the upper border of the liver, you know the liver's border sits horizontally. Therefore, your flat finger must be placed horizontally across the ribs.
Oh, because if you place your finger vertically, the sound wave will strike both the lung and liver simultaneously, creating a blurred, confusing note.
Right. You want the entire finger to cross the border at the exact same moment.
Okay, so we have the strict technique down. We are systematically tapping from the very top of the lungs, the apices above the collarbones, working our way down the front, the sides, and the back, always comparing the right side to the left side. What is the spectrum of acoustic sounds we are listening for?
There are 5 distinct notes on the percussion spectrum. We start at the center, the baseline, resonant. This is the sound of normal, healthy, perfectly aerated lung tissue. It is a low-pitched, clear, hollow sound that sustains for a brief moment.
First on the spectrum, resonance. That's our healthy baseline. Now let's move toward the less dense end of the spectrum. What if the lung has too much air? Like our emphysema patient with the hyperinflated alveoli.
When you percuss over a chest containing an abnormal excess of trapped air, the sound becomes hyper-resonant. It is noticeably louder, lower in pitch, and it booms for a longer duration than normal resonance.
And in our diagnostic matrix of 10 pathologies, you will primarily encounter hyperresonance in only 2 conditions, right? The first is emphysema, which will yield bilateral hyperresonance across the entire chest because the air trapping is systemic.
Correct. And the second condition is a pneumothorax. If a bleb on the lung surface ruptures, air leaks out of the lung and becomes trapped in the pleural cavity. The lung collapses inward, and the chest cavity fills with free air.
And when you percuss over that pocket of free air,
you will hear a loud, booming, unilateral hyperresonance on the affected side.
Okay, let me push the physics of that pneumothorax a bit further. What if it isn't just a simple leak? What if it's a tension pneumothorax? The patient has a flap tear in the lung. Every time they breathe in, air is sucked into the chest cavity, but when they breathe out, the flap closes and the air can't escape. It becomes a one-way valve. The chest cavity is actively being pumped full of air under immense life-threatening pressure.
A true medical emergency. And the physical exam reflects that extreme pressure. In a tension pneumothorax, the hyperresonance elevates to the third most extreme sound on the airy end of our spectrum, tympanic.
What does tympanic sound like, and why does the pressure change the note?
The term tympanic comes from the tympani, the large kettle drums in an orchestra. It literally sounds like tapping on a tightly stretched snare drum or an inflated balloon. It is a highly musical, high-pitched, ringing, hollow sound.
Why the higher pitch if it's still just air?
Because of the tension on the chest wall. As the pressure builds massively inside the pleural space, it pushes outward, stretching the intercostal muscles and the skin taut. Just like tightening the skin on a drumhead, increasing the tension raises the resonant frequency.
So hyperresonance becomes a tight musical tympani. And if you hear a tympanic note over the chest alongside severe respiratory distress, you are seconds away from cardiovascular collapse.
You must act immediately.
That covers the air side of the spectrum. Normal air is resonant, extra air is hyperresonant, pressurized air is tympanic. Now let's reverse direction. Let's go to the high density side of the spectrum. What if we remove the air and replace it with something solid or with fluid?
That brings us to the fourth sound on the spectrum, dull. When you tap over a dense, solid structure, like the normal anatomical liver on the right side or the heart on the left, the sound fundamentally changes. It becomes short, higher-pitched, and completely lacks any hollow resonance. It is a flat thud.
It's the sound of tapping your finger on a thick wooden table.
Exactly. In our pathology matrix, you will hear dullness whenever the normal air of the lung is replaced by density. You will hear dullness in consolidation because the alveoli are packed with dense fluid and pus.
You will hear dullness in lung collapse because all the air has been squeezed out and the tissue is just a dense, deflated knot.
Yes. And you will hear dullness in fibrosis because the spongy lung is replaced by thick, dense scar tissue.
But the clinical literature draws a very strict distinction between regular dullness and the fifth, final sound on our spectrum, stony dullness. What is the mechanical difference between a dull thud and a stony dull thud? How does it actually feel to the examiner's hands?
The physical sensation is a profound difference, and once you feel it, you never forget it. Regular dullness, like percussing over the liver, is a thud, but there is still a microscopic amount of elastic give to the biological tissue. The energy dissipates relatively smoothly.
But stony dullness.
Stony dullness is exactly what the name implies.
It feels like hitting a stone.
Tap your knuckles hard against a brick wall or against the thick, dense muscle of your own thigh. It is absolute dead flat sound with immense, painful tactile resistance. The acoustic energy doesn't dissipate smoothly. It bounces violently back into your joints. Your finger feels like it is hitting a solid rock wall.
And what pathological condition is the undisputed king of stony dullness?
A massive pleural effusion. When you have 1, 2, or even 3 liters of fluid pooling in the pleural cavity, compressing the lung out of the way and resting directly against the chest wall, the percussion note over that massive column of water is characteristically, undeniably stony dull. The sheer density of that volume of liquid provides absolute resistance to the percussion strike.
Let's tie this percussion sonar directly to what we would see on a radiological scan, because performing a physical exam is essentially just performing a biological X-ray with your hands, right?
The correlation between percussion notes and X-ray findings is perfectly binary. They are measuring the exact same physics. When you percuss over air, you hear resonance. On an X-ray, air has very low density, so it allows the radiation beams to pass straight through the body, hitting the film behind the patient and turning it black.
We call this hypertranslucency. Therefore, resonance equals black on the X-ray.
And dense tissue.
Conversely, when you percuss over solid tissue or fluid, you hear a dull thud. On an X-ray, solid mass or dense fluid blocks the radiation beams, preventing them from hitting the film, leaving that area bright white. We call this opacity. Therefore, dullness equals white on the X-ray.
That is incredibly satisfying. Black air, white fluid.
But let's stress test this. Let's look at 2 conditions from our matrix that both cause dullness: severe fibrosis and lobar collapse. In both cases, the lung has lost its aerated sponge-like quality. In collapse, the lung has completely deflated like a crushed paper bag. In fibrosis, it is turned into rigid, dense scar tissue. So I tap on both of them, they both sound dull.
They do.
How do we differentiate them using just our hands, and what does that physical difference look like when we finally see the X-ray?
The secret to differentiating them lies in the texture of the dullness as you map the chest. In a complete lobar collapse, an entire section of the lung has lost its air uniformly. It is folded in on itself to become a single, solid block of deflated tissue. Therefore, the dullness is homogeneous. Everywhere you tap your finger over that collapsed lobe, it sounds perfectly equally dull.
And on the X-ray, homogeneous dullness translates to a solid, uniform block of bright white.
Exactly. But fibrosis is architecturally different. Fibrotic disease rarely destroys the lung in a perfectly uniform block. It is chaotic. It creates thick, rigid bands of dense scar tissue, like ropes winding through the lung, but interspersed between those ropes are pockets of surviving, functional, air-filled alveoli.
It's a patchwork quilt of scar and air.
Precisely. So as you systematically percuss across a fibrotic lung, your finger will hit a dense scar band and you will hear a dull thud. Then you move your finger 1 inch lower, you percuss over a surviving air pocket, and you hear a resonant note. Move another inch, back to a dull thud.
It is a wildly mixed acoustic picture. We call this patchy or heterogeneous dullness.
And on the X-ray, it looks exactly like that. It's not a solid white block. It looks like a chaotic white storm cloud streaked with black pockets of surviving air.
Homogeneous dullness equals collapse. Heterogeneous patchy dullness equals fibrosis. You are deducing the internal architecture without ever needing a machine.
Before we leave the percussion module, I have to bring up a very specific, almost theatrical clinical scenario from the sources. Hydropneumothorax. Let's break down the word. Hydro means water. Pneumo means air. Thorax means chest cavity.
We have a patient who has both free fluid A and D free air simultaneously trapped in their pleural cavity.
It is a fascinating diagnostic challenge that highlights the absolute adherence of the body to fluid mechanics. Because the space is governed by simple gravity, the heavier substance, the fluid, will inevitably pool at the very bottom of the chest cavity. The lighter substance, the free air, will naturally rise to the very top.
And because they are trapped in a biological container, they separate completely, creating a perfectly horizontal line between the air and the water. The clinical term is an air fluid level.
Yes. So imagine this patient is sitting bolt upright on the edge of the examination bed. You begin percussing at the very top of their shoulder, moving downward towards their waist. What acoustic profile are you going to map?
Well, at the top, I am percussing over the rising trapped air. So I am going to hear loud, booming hyper-resonance. I keep moving my fingers down one rib space at a time. Hyper-resonant, hyper-resonant. And then suddenly, I cross that horizontal boundary line.
The moment you cross that perfectly horizontal boundary, you transition from tapping over air to tapping over dense fluid. The percussion note will instantly, drastically change from booming hyperresonance to a flat, dense dullness. You have physically located the exact air fluid border.
Okay, I have found a border where it changes from resonant on top to dull on the bottom. But here is the skeptical resident pushing back. How do I prove, beyond a shadow of a doubt, that this is a hydropneumothorax? What if this patient just happens to have normal resonant lungs at the top and a consolidated pneumonia sitting in the lower lobe? That would also be resonant on top and dull on the bottom.
That's a great differential. To prove that the underlying pathology is governed by free-flowing fluid and air rather than fixed tissue, you perform the ultimate mechanical test. The test for shifting dullness.
Shifting dullness.
While the patient is still sitting upright, you took a pen and you physically draw a mark on their chest, exactly where that horizontal border of dullness lies.
Okay, I have mapped the waterline.
Then you ask the patient to lie completely flat on their back, and you wait a few moments.
Because if it is a free-flowing pool of water, gravity is going to force that liquid to slosh backward and redistribute along the posterior wall of their chest, while the free air will bubble up to the anterior wall right against the front of their ribs.
Exactly. The fluid mechanics completely rearrange the internal landscape. Now, while they're lying flat, you take your percussing fingers and you tap directly on that pen mark you drew a minute ago.
When they were sitting up, that exact spot was below the waterline and sounded completely dull. Now that they are flat,
now the water has moved to their back and air has rushed to the front. So when you tap that same pen mark, it sounds hyper-resonant.
The boundary line has completely moved. The dullness has literally shifted.
It is pure, undeniable physics. A consolidated pneumonia is fixed, solid tissue. It will never shift, regardless of what position the patient is in. Only a free-flowing hydropneumothorax will demonstrate shifting dullness.
That is just brilliant. We have looked at the shape, we have felt the movement and the push-pull of pressure, and we have drummed on the chest to map the densities of air, scar, and water. Now, finally, we reach the fourth pillar. We place the stethoscope to the chest wall. Module 4, Auscultation, the Symphony of Breath.
Auscultation is the final layer of our diagnostic acoustic imaging. When we listen to a perfectly healthy aerated lung, we need to know the baseline sound. The physiological standard is called normal vesicular breathing.
How would you describe the acoustic profile of vesicular breathing?
It is a very gentle, soft, rustling sound. The classic textbook analogy, which is remarkably accurate, is the sound of a light wind blowing through the leaves of a distant tree. It is low in pitch, and it lacks any harsh, hollow, or tubular qualities.
But the true diagnostic key of normal vesicular breathing isn't just the rustling quality. It is the specific timing of the sound cycle. Let's think about the mechanical act of breathing. If I take a deep breath in and then let it out at a normal pace, the physical time it takes for my chest to expand inward is roughly equal to the time it takes for my chest to deflate outward. The mechanical movement is somewhat symmetrical.
Mechanically, yes. But the sound that we hear through the stethoscope completely defies that mechanical symmetry.
Right. In normal vesicular breathing, when the patient breathes in, the rustling sound is heard fully, loud and clear, continuously throughout the entire inward breath.
But when they begin to exhale,
the sound of expiration is only audible for the very first fraction of the outward breath.
no.
And then, bizarrely, the sound fades away completely into total silence, even though I can clearly see the patient's chest is still deflating and they are still exhaling air. Clinically, we summarize this by saying, inspiration is longer than expiration.
Which is a slight misnomer because the mechanical expiration isn't shorter, but the audible sound of expiration is drastically shorter.
Okay, we need to pause here and unpack the physiological why. Why does the sound vanish halfway through breathing out? If air is still moving through the pipes, shouldn't it be making noise? It comes down to the physics of turbulence and muscular effort, right?
It comes down entirely to turbulence. Sound in the respiratory tract is generated by turbulent airflow. The more chaotic and forceful the air movement, the louder the sound. Let's look at inspiration. Inspiration is a highly active physiological process. Your diaphragm forcefully contracts and pulls downward, while your intercostal muscles contract to lift your rib cage outward. You are utilizing significant muscular energy to rip open the thoracic cavity and create a powerful negative pressure vacuum, forcefully sucking air through the bronchi and deep into the alveoli.
So you have a continuous active muscular force dragging air through the branching tubes. That continuous high-speed force creates continuous chaotic turbulence, which generates a continuous inspiratory sound.
Exactly. But normal expiration is a completely different physiological state. Expiration is entirely passive. When you finish breathing in, your brain simply tells your respiratory muscles to turn off and relax.
We just let go.
You let go. And the immense network of elastic tissue built into your lungs naturally recoils, shrinking back to its resting state. Think of it exactly like letting go of a tightly stretched rubber band.
And if you let go of a stretched rubber band, the recoil force is explosive and strongest right at the very first millisecond of the release.
Precisely. At the exact moment expiration begins, the elastic recoil of the lung tissue is at its absolute maximum tension. It forcefully and rapidly squeezes the air out of the millions of microscopic alveoli, pushing it back into the larger bronchi. This sudden high-speed rush of air creates significant turbulence. Therefore, you hear a distinct expiratory sound at the very beginning of the outward breath.
But as the lung deflates...
As the lung loses volume, the tension on that elastic rubber band drops exponentially. The driving force weakens rapidly. The flow of air slows down, transitioning from chaotic turbulence to smooth laminar flow. Smoothly flowing air does not generate enough acoustic energy to cross the threshold of human hearing.
The air is still moving out, but it's moving too smoothly and quietly for the stethoscope to pick it up.
Yes. Therefore, the expiratory sound is short, abrupt, and quickly fades into silence, leaving you with the classic profile. Inspiration is fully heard, expiration is short and fading.
That perfectly explains the normal rustling sound with the short expiration. It's a symphony of active turbulence and passive recoil. But what happens when the very architecture of those tubes changes? Let's go back to our patients with severe airway, narrowing the patient having an asthma attack, or our barrel-chested COPD patient.
In those obstructive conditions, the internal lumen of the airways is heavily compromised. The bronchioles are clamped down by muscular spasm, swollen with chronic inflammation, or physically blocked by thick, tenacious mucus plugs. The tubes are narrow and highly resistant to flow.
So if the tubes are tiny and tight, that passive, relaxed rubber band recoil isn't going to be strong enough to push the air out.
It is nowhere near strong enough. Normal elastic recoil cannot overcome severe airway resistance. The passive expiration fails. In order to empty their lungs and avoid suffocating on trapped air, the patient is forced to recruit accessory muscles. They have to actively and forcefully squeeze their chest wall and abdominal muscles to physically crush the air out of the narrow tubes.
So expiration completely transforms. It goes from a relaxing passive deflation into a desperate, active, muscular struggle.
Yes. And because the patient is using immense muscular force to constantly push air through tight, narrow, highly resistant corridors, massive turbulence is generated continuously throughout the entire duration of the outward breath.
The turbulence never gets the chance to drop off into smooth flow.
Never. Consequently, the expiratory sound does not fade away. It persists loudly for the entire breath. When you listen with your stethoscope, the expiratory phase becomes incredibly drawn out. It becomes as long as, or sometimes significantly longer than, the inspiratory sound.
This is what we call prolonged expiration.
Prolonged expiration. It is the absolute hallmark sign of obstructive airway disease. If you hear expiration lasting as long as inspiration, you know immediately that the airways are narrowed and the patient is struggling to empty their lungs.
Prolonged expiration is our acoustic siren for blocked airways. But there is another breath sound on the spectrum, one that is considered the absolute star of auscultation. It is the one acoustic sign that, if you hear it over the chest, instantly tells you exactly what pathology is happening deep inside the tissue. I am talking about bronchial breathing. What does bronchial breathing actually sound like?
Bronchial breathing is striking. It is loud, harsh, and distinctly hollow or tubular. The pitch is notably high, and the tonal quality is rough. If you want to know exactly what it sounds like, take your stethoscope and place it directly over the front of your own neck, right over the cartilage of your trachea, and take a deep breath.
It sounds like Darth Vader, just a loud, rushing windpipe sound.
That is bronchial breathing.
But wait, it's perfectly normal to hear that loud tracheal sound over the trachea and the neck. The pathology occurs when we place our stethoscope way down over the outer lung fields, over the ribs, where we are supposed to hear that soft, gentle, rustling vesicular sound, and instead we hear the harsh Darth Vader windpipe sound roaring back at us. Why are we hearing the central windpipe sound transmitted all the way out to the edges of the lung?
To understand this, we must finally understand the acoustic purpose of the alveoli. We know that when air rushes down the large central trachea and the main bronchi, it inherently makes a loud, harsh, high-pitched noise. But in a healthy lung, as that sound wave travels outward toward the chest wall, it must pass through the millions of tiny, microscopic, air-filled alveolar sacs.
And we established earlier that air is a terrible conductor of sound.
It is. But more specifically, millions of tiny air pockets act as an incredibly efficient acoustic filter. The alveoli absorb and scatter the harsh, high-frequency sound waves from the central bronchi. They smooth the chaotic noise out, filtering away the harshness and delivering only that gentle, low-pitched, rustling vesicular whisper to your stethoscope.
The alveoli are the silencers on the engine. They muffle the roar.
A perfect mechanical analogy of the silencers. So let's look at the pathology of consolidation, our severe pneumonia patient, or a patient with a massive cavitation.
In pneumonia, the alveoli fill completely with dense fluid, pus, and inflammatory debris. They lose all of their air.
Exactly. The air is gone, which means the acoustic filter is completely wiped out. The silencer has been forcefully removed from the engine. Furthermore, as we proved in our TVF physics discussion, the fluid that has filled those alveoli is an incredibly highly efficient conductor of sound.
Oh, this is compounding.
What?
Not only did the disease remove the silencer, but it simultaneously laid down a high-speed, dense acoustic fiber optic cable running directly from the central bronchi straight to the chest wall.
Precisely. The harsh, unfiltered, loud, tubular sound of the central airways is broadcast directly and efficiently to your stethoscope without any dampening. You are hearing the central bronchi laid bare. This is bronchial breathing, and it is the definitive acoustic hallmark of consolidation or cavitation.
That is physiologically beautiful, but there is a very specific signature profile to the timing of bronchial breathing that distinguishes it. In normal breathing, they blend together. But in bronchial breathing, inspiration is loud, expiration is long and loud. But crucially, there is a distinct, undeniable pause, a silent acoustic gap right in the middle between inspiration and expiration.
Yes, the gap.
Why is there a gap? I am struggling to conceptualize why the roaring sound completely stops for a fraction of a second in the middle of a continuous fluid breath cycle.
It is one of the most brilliant mechanical details of the respiratory cycle. Think deeply about the normal vesicular breath sound again. We hear the full inspiratory sound in two continuous phases. First, we hear the air rushing through the bronchial tubes. Second, as the breath deepens, we hear the air expanding the millions of elastic alveoli.
Like a parachute opening.
Yes. That second phase, the alveolar expansion phase, is what seamlessly bridges the acoustic gap as the mechanics transition from breathing in to breathing out. The alveoli are still moving and settling as the breath turns around.
But in our pneumonia patient with bronchial breathing, the alveoli are packed full of concrete-like inflammatory fluid. They're totally solid. They aren't expanding like a parachute at all.
Precisely. The alveolar expansion phase is entirely missing from the mechanical cycle. When the patient breathes in, you hear the air aggressively hitting the rigid bronchial tubes. That is your loud inspiratory sound. But because the fluid-filled alveoli cannot inflate to accept the air, the internal air movement simply hits a brick wall and terminates abruptly.
The airflow stalls.
It stalls. There is a profound moment of absolute acoustic silence. The pause, while the gross muscular mechanics of the chest wall reverse direction from pulling in to pushing out. Then the chest wall squeezes down, and the patient actively forces the air back out through those rigid bronchial tubes, creating the long, harsh, expiratory sound.
So the gap is the sound of the air hitting a dead end. The presence of that silent pause is the definitive physiological proof that the spongy alveolar tissue has been replaced by a solid consolidated mass.
If you hear the harsh sound and the pause, you have found consolidation.
Okay, I am going to play the role of the skeptical, intense attending physician on rounds. Dr. Lerner, you claim you hear bronchial breathing and a pause over the patient's right lower lobe. You claim they have pneumonia. But the emergency room is loud, the patient is breathing weirdly, and the human ear can easily be deceived. How are you going to prove it to me right now without a chest x-ray?
If you suspect bronchial breathing, you never rely on just the breath sound alone. You immediately pivot to the 3 confirmatory tests of auscultation. These tests are specifically designed to exploit the acoustic conductivity of dense fluid to unequivocally prove that the tissue is consolidated.
Let's run through these tests as an escalating clinical challenge. I need to manipulate the sound waves to prove the density. Test number 1.
Test 1 is bronchophony. This is the auscultatory equivalent of tactile vocal fremitus. While you keep your stethoscope firmly placed over the suspicious area of the lung, you have the patient say that resonant word again, 99 or 44.
What should I hear normally?
Normally, over healthy, air-filled, filtering lung tissue, the patient's voice sounds heavily muffled, distant, and indistinct through the stethoscope. You can hear the low hum of a voice, but you cannot make out the crisp syllables.
But over our suspected consolidation?
Over a solid, fluid-filled consolidation, that high-speed acoustic conductivity takes over. The voice transmits without any filtering. Through the stethoscope, the spoken 99 sounds shockingly loud, intimately close, and terrifyingly clear. It sounds as though the patient has swallowed a microphone, and it is transmitting directly into your earpieces.
Okay, bronchophony is positive. It's incredibly loud. But maybe the patient just has a naturally booming voice. The attending physician is still not convinced. I need something more definitive. Test number 2.
Test 2 is egophony. This is a test of acoustic frequency filtering. You ask the patient to take a breath and say a sustained, continuous A sound.
E.
Now, a spoken E is a complex sound wave made up of both high frequencies and low frequencies. As that complex sound wave travels through the solid, fluid-filled mass of a consolidated lung, the dense fluid acts as an acoustic prism. It selectively transmits the high-frequency waves with extreme efficiency, but it aggressively filters out and traps the low-frequency waves.
So the sound is fundamentally altered as it travels through the fluid.
It is severely distorted. By the time that sound reaches your stethoscope on the chest wall, the pitch has shifted. The human E has bizarrely transformed into a harsh, nasal, bleeding sound.
Yeah.
It literally sounds exactly like the bleating of a goat. In fact, the word egophony comes from the Greek word a, meaning goat. If you ask the patient to say E, and you hear a distinct nasal goat-like A shifting through your stethoscope, you have positive egophony.
The goat bleat of pneumonia. That is an undeniable physical finding. But let's go for the absolute gold standard, the ultimate proof that the lung is solid. Test number 3.
The ultimate, irrefutable proof is whispering pectoriloquy. Pectoriloquy means chest speaking. You ask the patient to completely drop their vocal cords and simply whisper the word 99 very softly.
A whisper has almost no acoustic energy compared to spoken vocalization.
Exactly. Over a normal, healthy, air-filled lung, the delicate, low-energy sound waves of a whisper are instantly absorbed and destroyed by the massive volume of insulating air. You will hear absolutely nothing through the stethoscope. Total, dead silence.
But over the solid brick of a consolidated lung,
The dense fluid matrix conducts even the faintest, lowest energy acoustic wave with absolute crystalline perfection. When you listen over consolidation, you will hear that whispered 99 transmitted through the solid chest with chilling clarity. You will hear it as clearly and distinctly as if the patient's lips were an inch from your own ear, whispering a secret directly to you.
if whispering pectoriloquy is positive, the debate is over. The lung is consolidated. The physics of sound are completely unassailable.
Bronchophony, egophony, and whispering pictoriloquy, the trinity of consolidation.
We have mapped out the core breath sounds. But the lungs are noisy organs. They produce a vast array of other noises, added sounds, extraneous acoustic layers sitting on top of the underlying breathing cycle. This takes us into Module 5, focusing on crackles, wheezes, and a very secret anatomical spine sign. Let's start with the crackles, clinically known in the older literature as crepitations.
Crackles are precisely what they sound like. They are discontinuous, explosive, non-musical, very brief acoustic events. They are a rapid series of tiny acoustic pops.
The classic visual analogy is the sound of a bubbling hookah pipe, or pouring milk over Rice Krispies. Or if you want a physical analog you can do right now, take a dry lock of your own hair and rub it firmly between your thumb and forefinger right next to your ear. That dry, crackling, popping friction sound. What mechanical event is occurring deep inside the lung tissue to generate those pops?
There are two primary pathophysiological mechanisms that create crackles. The first mechanism is governed by fluid dynamics. Imagine the tiny microscopic alveolar sacs at the ends of the airways. In conditions like early pneumonia or early pulmonary edema from heart failure, these sacs become partially filled with a thin layer of sticky, inflammatory exudate or backup fluid.
So the walls of the microscopic balloons are wet and sticky. When the patient breathes out, the balloon deflates and the sticky, wet walls touch and stick together.
Exactly. And when the patient forcefully breathes in again, a rush of air attempts to reinflate that collapsed, sticky sac. The air bubbles violently through the thin layer of fluid, physically snapping the sticky walls of the alveolus apart.
The acoustic energy of millions of sticky microscopic bubbles violently popping open under air pressure translates into the sound of crackles.
That is the fluid mechanism. The second mechanism is governed by structural fibrosis. In severe interstitial lung disease, the delicate alveoli are surrounded and heavily infiltrated by thick, unyielding, rigid scar tissue. The lung loses its natural elastic compliance.
It's no longer a soft balloon. It's a stiff, scarred leather pouch.
When the inspiratory vacuum tries to inflate those stiff fibrotic alveoli, they do not expand smoothly or continuously. They resist the pressure until a critical threshold is reached, and then they snap open suddenly and violently.
It's the physical tearing apart of stiff surfaces, like forcefully ripping apart two strips of Velcro.
The Velcro crackle is a classic descriptor for fibrotic lung disease. So fluid bubbles popping or fibrotic tissue snapping open, both generate the acoustic signature of crackles.
But the clinical literature goes much deeper than just hearing a crackle. The actual pitch and timing of these crackles provides a sequential map of disease progression. There is a massive clinical pearl regarding the chronological timeline of pneumonia and how it directly alters the pitch of the crackles.
This is a beautiful demonstration of how pathology evolves anatomically. Crackles are categorized strictly by their pitch and acoustic quality: fine, medium, and coarse. Let's trace the timeline of a lobar pneumonia.
Day 1.
In the very early nascent stages of pneumonia, often before the patient even feels severely ill, the inflammatory process is just beginning. The fluid exudate is minimal, and it is located incredibly deep, solely within the smallest, most microscopic terminal alveoli. Snapping these tiny microscopic structures open under high pressure produces fine crackles.
Fine crackles. Very high-pitched, very delicate, exactly like rubbing the lock of hair next to your ear. They happen right at the very end of taking a deep breath in as the final tiny sacs pop open.
Correct. But as the days pass and the bacterial infection worsens,
The inflammation explodes.
the sheer burden of the inflammatory fluid increases massively. The fluid volume overflows the microscopic alveoli and begins moving slightly upward into the larger respiratory bronchioles. Bubbling massive amounts of air through these slightly larger airways produces medium crackles.
Louder, slightly lower in pitch, like popcorn rapidly popping in a microwave.
Exactly. Finally, in the late resolving stages of pneumonia, or in chronic severe tissue-destroying pathologies like a massive lung abscess or bronchiectasis, the incredibly thick, purulent secretions and heavy fluid pool massively in the large main bronchi and the trachea itself. The gross volume of air aggressively gurgling through these large central pipes creates coarse crackles.
Coarse crackles are loud, very low-pitched, harsh, bubbling sounds. You can often hear them even without a stethoscope, just standing next to the bed. The death rattle is essentially a terminal coarse crackle, so the timeline is clear. Fine crackles early in the deep microscopic tissue, medium crackles in the middle bronchioles, coarse crackles late in the large central pipes.
It maps the anatomical progression of the fluid volume.
But here's the resident's dilemma. I am examining an otherwise healthy patient who just woke up. I listen to their bases, and I hear a few crackles. How do I know if those crackles are the terrifying fine crackles of an impending deadly pneumonia, or if the patient just has a little bit of benign, normal mucus pooling in their throat from sleeping?
You never guess. You perform the absolute mandatory clinical maneuver, the cough test. The moment you hear crackles of any pitch, you keep your stethoscope firmly on the chest and you command the patient to take a deep breath and cough as forcefully as they possibly can.
Why does a cough differentiate the pathology?
A forceful cough generates hurricane-level wind speeds inside the large airways, designed to blast away loose debris. If the crackles completely disappear after the patient coughs, it means you were simply hearing transient, loose, benign mucus secretions rattling around the larger airways that have now been mechanically cleared away.
But if it's pneumonia?
A cough cannot generate enough force to clear heavy inflammatory fluid trapped deep inside the microscopic alveolar tissue or the structural scarring of fibrosis. If the crackles persist entirely unchanged despite a vigorous clearing cough, it confirms unequivocally that the sound is originating from fixed organic pathology deep in the lung parenchyma.
The cough test clears the static. Brilliant. Okay, from the discontinuous popping explosions of crackles, we move to the continuous drawn-out musical notes of wheezes, which older literature often refers to as runchy.
If a crackle is a fluid bubble bursting, a wheeze is the acoustic sound of a pinched balloon. Think about the physical act of inflating a toy rubber balloon, pinching the rubber neck tight with your fingers, and slowly letting the air escape.
It squeaks loudly. It makes a continuous, high-pitched, intensely musical whistling sound.
That exact physics occurs inside the human lung when the tubular airways are diffusely narrowed. Whether they are narrowed by the severe muscular spasms of an asthma attack, the chronic swollen inflammation of bronchitis, or blocked by thick, sticky mucosal secretions, the airway acts like the pinched neck of the balloon.
Air is being forcefully squeezed through a violently constricted pipe, creating intense musical turbulence. And just like crackles, wheezes come in very different pitches based on the anatomical size of the pipe being squeezed, right?
The physics of the pipe determine the pitch. If the pathological narrowing is occurring deep in the periphery of the lung, within the tiny microscopic terminal bronchioles, the air rapidly squeaking through those tiny apertures produces a very high-pitched, sharp, hissing or whistling sound. We classify this as a sibilant wheeze.
Sibilant means hissing, like a snake.
However, if the pathological narrowing is happening higher up the anatomical tree, within the large, wide, main lobar bronchi, perhaps due to a large tumor partially blocking the airway, or a massive plug of thick mucus, the vast volume of air vibrating that large structure produces a much lower-pitched, deep, resonant rumbling or snoring sound. We classify this as a sonorous wheeze.
Sonorous meaning deep and full. So sibilant equals tiny peripheral pipes, sonorous equals large central pipes. So what do we hear in a patient suffering a massive exacerbation of severe asthma or end-stage COPD? Because those diseases don't just pick one pipe to narrow, they ravage the entire lung architecture simultaneously.
In severe asthma and COPD, the inflammatory narrowing is ubiquitous and chaotic. It severely affects the tiny microscopic airways, the medium bronchioles, and the large main bronchi, all at the exact same time. Every pipe is a different size, and every pipe is squeezing shut.
So if I listen with my stethoscope, I'm not just going to hear one clean whistling pitch.
You are going to hear an absolute acoustic cacophony. You will hear multiple different pitches, high-pitched hisses from the tiny airways and low-pitched rumbles from the large airways, all overlapping, clashing, and playing simultaneously. This complex, multitonal sound is called a polyphonic wheeze.
Polyphonic. Many sounds. It sounds like a broken, untuned orchestra warming up.
A polyphonic wheeze is the absolute, undeniable acoustic hallmark of severe, diffuse obstructive lung disease.
And crucially, this ties perfectly back to our earlier discussion on the mechanical cycle of breathing. When do we hear these wheezes the loudest? Are they louder when the patient breathes in or when they breathe out?
Overwhelmingly, wheezes are loudest and most prominent during expiration. We must return to the structural physics we discussed with prolonged expiration. Inspiration is an active, expansive process. The chest cavity expands outward, which physically creates radial traction. It literally pulls the airways open wider.
So even if the airway is inflamed and narrowed, the physical act of breathing in stretches it open just enough to let the air slide past without too much whistling.
Exactly. But expiration is passive and compressive. The chest cavity collapses inward. This positive intrathoracic pressure violently compresses the already inflamed, thickened, narrowed airways from the outside, crushing them down, making the pipes even tighter. The air has to desperately squeeze through these brutally constricted, compressed pipes, creating immense friction, intense turbulence, and the loud, musical polyphonic wheeze. Expiration is the hardest, most physically taxing part of breathing for these patients. The wheeze is the sound of that struggle.
The mechanical connections are flawless. Now, before we finally assemble our 10 pathologies matrix, we have to talk about the secret spine sign, Diaspine's sign. This feels like a deeply hidden, almost forgotten Easter egg of classical clinical medicine. It relies entirely on understanding invisible internal anatomy.
Diaspine's sign is an exquisite, high-level clinical test. It is a perfect example of using external acoustic markers to detect hidden central masses deep within the chest cavity that you cannot see or percuss. It requires a precise understanding of exactly where the major airway structures sit relative to the bones of the spine.
Okay, set the invisible anatomical stage for us. Where are the pipes hidden?
The large central trachea travels vertically down the exact center of the upper chest. Eventually, it reaches a point where it bifurcates. It physically splits into the right main bronchus and the left main bronchus. Anatomically, this major bifurcation occurs at the exact horizontal level of the fourth thoracic vertebral body in the spine.
Okay, the split happens at thoracic vertebra number 4, or T4, but there is a physical problem for the examiner. The vertebral bodies are massive blocks of bone buried deep inside the center of the chest cavity. I can't touch T4, I can only touch the spinous processes, the sharp, bony bumps sticking out of the skin on the patient's back.
And because of the steep downward angle at which those bony spinous processes project from the vertebral bodies, the anatomical landmarks don't align perfectly horizontally. The deep fourth thoracic vertebral body aligns horizontally with the surface spinous process of the second thoracic vertebra, or T2.
Okay, so the bony bump of T2 on the surface of the skin perfectly marks the invisible tracheal split deep inside the chest.
Correct. Therefore, if you take your stethoscope and place it directly on the bone of the patient's spine above the T2 level, you are listening directly over the solid, singular pipe of the trachea. Because you are directly over the massive airway, you will hear normal, physiological bronchial breathing, loud, harsh, hollow, tubular sound.
That makes sense. You were right over the primary wind tunnel.
But once you move your stethoscope exactly 1 inch down to listen below the T2 level, the anatomical reality changes. The trachea has ended. The main bronchi have plunged outward, deep into the spongy, air-filled matrix of the lungs.
And as we know, the millions of air-filled alveoli surrounding those lower bronchi act as heavy acoustic insulators and silencers.
Exactly. Therefore, below the T2 level, the harsh tracheal sound should be completely filtered out by the surrounding lung tissue. You should only hear soft, rustling vesicular breathing over the spine below T2. You should absolutely never, ever hear loud bronchial breathing over the spine below that cutoff.
But if the spine sign is positive, you do.
Yes. If you place your stethoscope below T2, and you hear harsh, loud, tubular bronchial breathing roaring up the spine, something is terribly structurally wrong. It means there is a massive, solid, dense structure sitting right in the middle of the mediastinum, the central compartment of the chest.
And that solid mass is acting as an acoustic bridge. It is bypassing the airy lung tissue and conducting the loud tracheal roar directly from the bifurcation straight back to the bones of the spine.
It acts as an abnormal acoustic cable.
And what kind of massive, solid structures hide silently in the mediastinum?
Classically, profoundly enlarged mediastinal lymph nodes, a massive cluster of dense lymphatic tissue. This is an enormous red flag for severe systemic pathologies. Massive mediastinal lymphadenopathy is a hallmark of severe tuberculosis, advanced sarcoidosis, aggressive lymphoma, or a central metastasizing lung cancer.
Hearing a harsh breath sound below the second thoracic bone, a positive to spine sign, allows you to clinically deduce the presence of a massive hidden tumor or lymph node cluster without a single radiological scan. That is the sheer magic of clinical medicine. You're using physics to see through the body.
It is diagnostic elegance.
All right. We have gathered every single puzzle piece. We understand the physics of visual movement, the mechanical push and pull of internal pressure, the acoustic vibrations of tissue density, the sonar of percussion, and the fluid dynamics of breath sounds. We are ready for Module 6, the culmination of everything, the 10 pathologies matrix.
This is the crescendo. If you are a medical resident listening to this, this is the moment where you synthesize the disparate pieces into a cohesive framework. We are going to aggressively stress test the absolute rules we have established against the 10 core chest diseases. We will prove that you do not need to memorize a list of symptoms, you just need to apply the logic of physics to the clinical presentation.
We're going to do a deep, rapid-fire clinical case application. I will throw out a hypothetical patient scenario comparing two conditions that often seem similar, and we will use the rules of the matrix to break them apart step by step.
Let's begin.
Case pair 1. A patient presents with sharp, stabbing chest pain every time they take a breath. We need to differentiate pleurisy versus an early pleural effusion. In pleurisy, the pleura, the delicate double lining of the lung, is severely inflamed and painfully rubbing together, but there is no actual fluid accumulating yet.
We run the matrix. Inspection. If there is no massive volume of fluid taking up space, there is no mechanical bulge. Therefore, the shape of the chest is perfectly normal. Rule 1 applies. Because the patient is in agonizing pain, they will subconsciously splint their chest, meaning movement is decreased on the affected side.
Palpation.
Because the shape and volume are normal, there is no pressure pushing or pulling the mediastinum. The trachea remains perfectly central. Because it is strictly surface inflammation, the underlying lung tissue itself remains normally aerated. Therefore, tactile vocal fremitus is entirely normal.
Percussion and auscultation.
Because there is no dense fluid, percussion remains normally resonant. Because the airways and alveoli are unaffected, the breath sounds remain normal vesicular. The only abnormal acoustic sign might be a harsh, grating friction rub sound as the inflamed linings scrape against each other. Pleurisy is a disease of pain, not a disease of altered density.
But let's say we see that same patient 3 days later. The intense inflammation has caused the pleura to weep liters of fluid into the chest cavity. The pleurisy has evolved into a massive pleural effusion.
Instantly, the physics matrix completely shifts. Inspection. The massive volume of fluid takes up immense space, creating a visible unilateral bulge. Movement remains decreased. Palpation. That massive fluid bulge acts as a hydraulic ram, increasing pressure and pushing the trachea far to the opposite healthy side.
The acoustics completely flip.
The thick wall of fluid acts as an impenetrable acoustic insulator. Tactile vocal fremitus dropped to 0. Percussion. Tapping over that massive lake of fluid yields a painful, dead, stony dullness. Auscultation. The fluid barrier blocks all sound, resulting in absent breath sounds. The physics dictate every single finding.
A complete physical transformation, entirely predictable by fluid mechanics. Let's move to case pair 2, the negative syndrome. You mentioned earlier that there is a triad of severe conditions that look essentially identical on almost every primary metric because every finding is suppressed.
Yes, the ultimate differential diagnosis trio. A pleural effusion, a complete lobar collapse, and severe fibrosis. In all three of these devastating conditions, the fundamental pillars of the physical exam hit rock bottom.
Let's run the matrix to see why they mimic each other.
In all three, chest movement is severely decreased. Tactile vocal fremitus is severely decreased in effusion because the fluid acts as an acoustic insulator. In collapse because the dense folded tissue blocks the sound waves. In fibrosis because the thick, rigid scar prevents vibration.
Percussion and auscultation.
In all three, percussion is dull. The air has been replaced by dense fluid, deflated tissue, or heavy scar. And in all three, the breath sounds are severely decreased or completely absent. Everything is negative. Everything is suppressed.
So if I'm the resident, and I have a patient presenting with universally decreased movement, completely dead TVF, dull percussion, and silent breath sounds, how on earth do I know which of the three conditions is actually killing them? I can't just guess.
You apply the specific clinical tiebreakers based on architectural nuance. Let's separate fibrosis from collapse first. As we establish, both produce a dull percussion note because the air is gone, but you evaluate the texture. Fibrosis is a chaotic web of scars interspersed with air pockets, so the dullness is patchy and heterogeneous. Collapse is a solid block of deflated tissue, so the dullness is uniform and homogeneous.
And we apply the stethoscope tiebreaker.
In a complete lung collapse, the airways are crushed or blocked. There is absolutely no air moving through that solid block of tissue, so you hear absolute silence, no added sounds. But in fibrosis, you still have air trying to force its way into those stiff, scarred alveoli. So in fibrosis, as those scarred sacs snap open, you will hear crisp, explosive crackles. In collapse, there are no crackles.
Brilliant logic. Patchy dullness plus crackles equals fibrosis. Homogeneous dullness plus total silence equals collapse. And to separate those two from a pleural effusion, we look for the stony dullness and the tracheal push of the fluid versus the tracheal pull of the shrinking fibrosis and collapse.
The matrix always provides a path to the answer.
Let's move to case pair 3. This one is incredibly tricky because it involves the only two conditions that actually increase the acoustic vibrations: Consolidation, which is our severe pneumonia, versus cavitation, which is a massive lung abscess.
This pairing is where the physical exam hits its absolute physiological limit. It is a vital lesson in clinical humility. Let us run the matrix for a patient with a severe right-sided consolidation.
Inspection. Movement is decreased, but because the fluid is replacing the air inside the existing alveoli, there is no massive extra volume added. The chest shape remains normal. Palpation. Because there is no massive bulge or retraction, the internal pressures are stable. The trachea remains perfectly central.
Now the acoustics. Because the spongy air is replaced by dense, highly conductive fluid, tactile vocal fremitus is heavily increased. Percussion over that dense solid tissue is a dull thud. Auscultation reveals the loss of the alveolar milter, giving you loud, harsh bronchial breathing with a distinct pause, and bubbling through that fluid creates crackles.
Okay, that is the exact, undeniable profile of consolidation. Now, what if the patient actually has a massive cavitation? A thick-walled cavity filled with a pool of fluid and air. We run the matrix.
Inspection. Decreased movement, normal shape, palpation, central trachea, acoustics. The dense wall of the cavity and the fluid pool are excellent conductors. Therefore, TEF is heavily increased. Percussion over the thick wall is dull. Auscultation reveals bronchial breathing transmitted through the cavity, and bubbling fluid creates crackles.
Yeah. Normal shape, central trachea, dull percussion, heavily increased TVF, loud bronchial breathing, and crackles. The clinical profile for consolidation and the clinical profile for cavitation are identical.
They are completely 100% indistinguishable by physical exam alone. The acoustic physics of fluid-filled microscopic alveoli and a massive fluid-filled macroscopic cavity are identical to your hands and your stethoscope.
So if the physics are identical, how do you make the final call on the ward?
This is where you must step back from the chest wall and treat the human being. You integrate the patient's history. You ask them about their timeline. A raging, acute, high-spiking fever with a cough that started 48 hours ago strongly suggests an acute consolidation like pneumonia. Conversely, weeks or months of a slow-burning fever, weight loss, and coughing up massive amounts of foul-smelling, putrid sputum suggest the necrotic decay of a lung abscess cavity.
The history provides the context the hands cannot feel.
And inevitably, you order the X-ray. Consolidation presents radiologically as a solid, fluffy white opacity. A cavitation presents as a thick-walled white ring, often containing that perfect horizontal air fluid level line we discussed earlier. The physical exam isolates the physics of density. The history and the imaging paint the specific pathological reality.
Okay, final case profile for the matrix. We need to build a complete picture of the severe emphysema and COPD patient, the end-stage air trapper. How do they present across all four pillars?
They are the ultimate embodiment of chronic hyperinflation and severe obstruction. Inspection. They present with a profound bilateral barrel chest due to decades of relentless air trapping remodeling their rib cage. The ratio is 1:1. Movement is globally symmetrically decreased because the chest wall is already stretched to its absolute maximum mechanical limit. It physically cannot expand any further.
Palpation.
Because the hyperinflation bilateral and symmetrical, the crushing pressures on the mediastinum are equal from both sides. Therefore, the trachea remains perfectly central.
Acoustics and percussion.
Because their lungs are massively overfilled with excess air, and air is a terrible acoustic conductor, their tactile vocal fremitus is globally, universally decreased across the entire chest. When you strike the chest wall, the immense volume of trapped gas causes it to boom like a kettle drum widespread bilateral hyper-resonance.
And finally, auscultation, the symphony of breath.
You hear the ultimate struggle of obstruction? The breath sounds are globally decreased because the airflow is so poor. You hear a severely prolonged expiratory phase as the patient recruits every accessory muscle to aggressively fight to force the trapped air out of their crushed airways. And riding on top of that prolonged outward breath is the harsh musical cacophony of expiratory polyphonic wheezes, signaling that every pipe in their lung is squeezing shut.
It is a perfect, logical, cascading sequence. The matrix is complete. Inspection, palpation, percussion, auscultation. 10 core pathologies. Once you understand the underlying physics, once you truly understand fluid mechanics, acoustic conductivity, and impedance mismatch, you never have to blindly memorize a random list of symptoms again. You can stand at the bedside of a crashing patient, place your bare hands on their chest, and logically deduce the exact internal structural integrity of their lungs in real time.
That is the very essence of clinical mastery. The biological rules do not bend. If you rigorously follow the physics, the diagnosis has no choice but to reveal itself to you.
This has been an incredibly rigorous, demanding journey through the mechanics of the human body. We have learned that the lungs aren't just simple, spongy bags of air inflating and deflating. They are highly complex, dynamic, acoustic resonance chambers. Whether they are overinflated with trapped gas and emphysema, short-circuited by dense fluid and pneumonia, heavily insulated by a pleural effusion, or pulled taut by the rigid scars of fibrosis, the strict, unyielding laws of physics will dictate exactly how they vibrate, how they resonate, and how they sound to the trained ear.
We have translated highly abstract textbook medical concepts into tangible mechanical realities. By treating the human chest as a drum to be percussed, a flute to be wheezed through, and a resonance chamber to transmit voice, we entirely demystify the pathology.
And that leads me to a final, somewhat provocative thought to leave you with, especially if you are a learner training in today's medical system. In modern medicine, the absolute second a patient walks into the emergency room complaining of a severe cough, shortness of breath, or chest pain, the knee-jerk, almost automatic reaction is to immediately order a high-resolution CT scan or a digital X-ray. The glowing, pixelated screen has become our ultimate arbiter of clinical truth. We trust the machine implicitly. But this deep dive proves, beyond a shadow of a doubt, that the human body acts as its own incredibly sophisticated biological imaging machine. It is constantly broadcasting its precise internal state through mechanical vibrations, shifts in pitch, changes in pressure, and acoustic resonance.
It's a profound art that is rapidly being lost to the convenience of technology.
It truly is, and it makes you wonder, what happens to the diagnostic intuition, the critical thinking, and the fundamental tactile connection of future doctors if we stop placing our hands on the patient's chest? If we stop listening to the internal symphony of the body's physics and only ever look at the black and white pixels on a screen? Are we trading the deep, physical, intimate understanding of our patient's physiology for the sheer convenience of a machine?
A vital, existential question for the next generation of clinicians to answer.
To everyone listening, thank you for joining us on this exhaustive, massive deep dive into the masterclass of chest examination. Keep learning, keep pushing for the why behind the what, and never, ever stop listening to the incredible stories the human body tells us.